Acne. Definition. Acne vulgaris, common acne, is a disorder affecting pilosebaceous units in the skin. The cause is multifactorial. Clinical lesions range from non-inflamed comedones to inflammatory papules, pustules, and nodules. Key points. 1. Acne is the most common dermatologic disease with negative psychosocial ramifications. 2. Comedones are the hallmark of the disease. 3. Treatment targets multifactorial causes of acne. Androgens, follicular obstruction, and Cutibacterium, formerly Propionibacterium, Acnes. Acne, characteristic papules and pustules in a teenager. Incidence. Acne is the most common disease seen by a dermatologist. It begins at a surprisingly young age. Comedones can be found on examination in 50% of boys aged 9 to 11 years. Acne is a physically and psychologically devastating condition and must be treated aggressively. The incidence and severity of the disease increase during the teenage years and early adulthood, affecting approximately 85% of young people between the ages of 12 and 24 years. Contrary to popular belief, acne is not confined to teenagers. It may continue into the third and fourth decades of life, especially in women. In some patients, it does not begin until then. Adult female acne is an increasingly recognized condition, defined as a type of acne in women aged 25 years or older, and the acne can persist even after 50 years of age. History. The patient usually makes the diagnosis and often has attempted therapy with over-the-counter medication. A history of hirsutism, hair thinning usually localized to the top of the scalp, or irregular menses in a woman with acne should lead to the consideration of possible androgen excess. Adult women often complain of acne along the jawline that worsens around the time of menstruation. In ethnicities with darker skin, acne can often lead to marks of post-inflammatory hyperpigmentation, which can take many months to resolve without treatment. Topical or systemic corticosteroids can also cause an acneiform eruption. Adult female acne, papules and post-inflammatory hyperpigmented macules along the jawline. Note hirsutism indicating possible androgen excess. Physical examination. The less inflamed lesions in acne are called comedones and are of two types. 1. The open comedone or blackhead, which appears as a dilated pore filled with black keratinous material, not dirt, and 2. The closed comedone or whitehead, which is a small, flesh-colored, dome-shaped papule that is often difficult to see. It is now recognized that comedones are associated with inflammation. Inflammatory acne lesions are seen more easily by both the patient and the physician. They appear as papules, pustules, or nodules, depending on the magnitude of the inflammatory response. Acne is found in areas with numerous sebaceous glands, usually the face and upper trunk. The lower trunk is less often involved, and the distal extremities are always spared. Adult female acne, which has a hormonal component, affects the periphery of the face, mainly the jawline, chin, and upper neck. A. Closed comedones or whiteheads. B. Open comedones or blackheads. Less inflammatory lesions. 1. Open comedones. 2. Closed comedones. Inflammatory lesions. 1. Papules. 2. Pustules. 3. Nodules. Acne, papules and pustules. Note post-inflammatory hyperpigmented macules. Differential diagnosis. The diagnosis of acne is rarely difficult, particularly in teenagers. Occasionally, acne comedones may be confused with flat warts, which are small, flesh-colored, flat-topped papules usually located on the face. On close inspection, the flat wart is seen to have a sharp right-angled edge and a finely textured surface, whereas a closed comedone has a dome-shaped, smooth surface. Flat warts, flesh-colored papules often mistaken for acne. Steroid acne is caused by the use of corticosteroids and is distinguished from acne vulgaris by its sudden onset, usually within 2 weeks of starting high-dose systemic or potent topical corticosteroid therapy, and appearance, uniform, 2 to 3 mm, red, firm papules and pustules. Steroid acne caused by topically applied agents occurs most often on the face. With systemic corticosteroids, the eruption is most prominent on the upper trunk. Steroid acne. Uniform, red papules in a kidney transplant patient on high doses of systemic steroids. Pustular acne vulgaris can be confused with bacterial folliculitis or rosacea. In bacterial folliculitis, hairs are visible in the center of some of the pustules, and a bacterial culture is positive, usually for Staphylococcus aureus or, less often, for a gram-negative organism. Rosacea is distinguished from acne vulgaris by the presence of a background blush of erythema and telangiectasia and the absence of comedones. Rosacea also usually occurs later in life. Angiofibromas, a skin manifestation of tuberous sclerosis, are often incorrectly diagnosed as acne. Clinically, the lesions appear as firm, pink papules that are clustered primarily in the center of the face, are persistent, and are, of course, resistant to acne therapy. Keratosis pilaris, when it affects the facial cheeks, is distinguished from acne by its minute, rough, uniform papules on the background of red, prominent skin vasculature, skin and by its lack of comedones. Keratosis pilaris is a chronic condition and is relatively unresponsive to acne treatments. Tuberous sclerosis. Multiple reddish, brown papules on central face in a black child, often confused for acne. Differential diagnosis of acne. Flat warts. Steroid acne. Folliculitis. Rosacea. Angiofibromas in tuberous sclerosis. Keratosis pilaris. Laboratory and biopsy. The diagnosis is almost always made clinically. Occasionally, a bacterial culture is indicated to rule out infection. A biopsy is not indicated but would show an occluded pilosebaceous unit along with inflammation. Acne. Epidermis. Intraepidermal, intrafollicular collection of neutrophils. Dermis, occluded pilosebaceous unit with the accumulation of keratin, sebum, and inflammatory cells. Extravasation of material through the ruptured wall leads to further dermal inflammation. Therapy. Four categories of medication have proved efficacious in the treatment of acne: topical agents, systemic antibiotics, systemic retinoids, and hormonal agents. The type of acne guides the choice of treatment. For the majority of patients, systemic retinoids and hormonal therapy are not required. Topical agents. Topical agents are most effective for superficial lesions. For comedones, the mainstay of treatment remains topical retinoids, tretinoin, Retin-A micro cream. Adapalene, Differin cream 0.3% prescription or over-the-counter adapalene gel 0.1%, and tazarotene, Tazorac. Benzoyl peroxide has mild comedolytic activity and also exerts an antibacterial effect. Topical antibiotics, erythromycin and clindamycin, should be used in combination with topical benzoyl peroxide to prevent bacterial resistance. Newer medications have emerged for topical therapy. Clascoterone 1% cream, Winlevi. A topical androgen receptor inhibitor and the first of its kind, can be applied to affected areas twice daily. It is approved by the U.S. Food and Drug Administration, FDA, for patients aged 12 years and older. Another newer medication is the topical antibiotic, 4% minocycline foam, Amzeeq, applied once daily. It is FDA approved only for patients with moderate to severe acne. The most common side effects of the topical antibiotic include headaches and increased creatinine phosphokinase levels. In addition, patients must be advised that retinoids and benzoyl peroxide preparations can cause skin irritation, which is usually worse during the first 1 to 2 weeks of use and afterward diminishes. In part because of the irritation, the patient may notice that the condition appears worse rather than better after the first several weeks of use. Systemic antibiotics. Systemic antibiotics are indicated in patients with inflammatory papules or pustules, especially if there is truncal involvement. Doxycycline, 50 to 100 mg twice daily, is the most commonly prescribed oral antibiotic because of its efficacy and relative safety. Minocycline, 100 mg twice daily, is used mostly in people who cannot tolerate doxycycline. A newer tetracycline, sarecycline, is an oral weight-based pill given once daily, is more specific to Cutibacterium acnes, and has the potential for less disruption of the gut microbiome. Tetracycline, 500 mg twice daily, is less commonly prescribed. We must try to limit systemic antibiotic use to no more than 3 months. To promote compliance, we recommend taking tetracyclines with food and even dairy products, despite package insert recommendations. Systemic retinoids. The oral retinoid Isotretinoin became available commercially in September 1982 for use in the treatment of patients with severe acne. This potent vitamin A analog decreases inflammation, follicular keratinization, sebum production, and intrafollicular bacterial counts. Side effects are common. Almost all patients experience chapped lips and dry skin, and extracutaneous complications also occur, for example, increased levels of liver enzymes and plasma lipids. Most importantly, systemic retinoids are teratogenic. It is mandatory that patients who can get pregnant should not become so when taking isotretinoin. Special consent forms, strict birth control measures, and monthly pregnancy tests are required for patients who can get pregnant taking isotretinoin. A consent form acknowledging the risk of depression and suicide while on isotretinoin is required for all patients. There is also a controversial link between isotretinoin and inflammatory bowel disease. Because of these restrictions, the drug is recommended mainly for the treatment of patients with severe, therapy-resistant papular, pustular acne or scarring nodular acne. Acne. A. Before isotretinoin application. Severe nodular, cystic acne with scarring. B. After isotretinoin application. Acne. A. Severe nodular acne with papules, pustules, and scarring. Acne. B. Note post-inflammatory hyperpigmentation from the scarring acne in a patient with darker skin type.
Hormonal therapy. This class of treatment can help females who have acne that fails to respond to initial treatment outlined above and that flares with their menstrual cycle. Spironolactone 50 to 100 mg twice daily has become a first-line therapy for adult female acne. In healthy females, it is not necessary to monitor lab work, mainly potassium levels. Side effects of spironolactone include breast tenderness and menstrual irregularity. These can be prevented by also prescribing oral contraceptive pills. Birth control pills with low androgenicity improve acne in many patients. Several products are available, including orthotricycline and estrostep, for which the FDA has approved acne as an indicated use. Hormonal therapy should be prescribed only by physicians who are fully aware of its potential side effects. Patient education. The most important aspect of a successful acne treatment program is patient compliance. Instructions should be given both verbally at the time of the patient's initial visit and on a written take-home sheet that reinforces what was said. Patients are best able to comply if medications are used only twice daily, so that the medication schedule can be centered on an already established daily habit such as teeth brushing. At the time of the initial visit, answers can also be given to several common questions, often unasked, that patients with acne or their parents frequently have regarding the following. 1. Diet. Some evidence indicates that a Western diet may have an adverse effect on acne, but specific foods have not been implicated. For most patients, a sensible diet is all that is suggested. 2. Cleanliness. Acne is not a function of poor hygiene. In general, acne cleansing agents are also not recommended because they cause irritation that unnecessarily compounds the irritation from the recommended topical comedolalytics. Instruct patients to wash their face with their hands and not with a washcloth. 3. Cosmetics. If cosmetics are used, they should be water-based and used sparingly. Most cosmetic products are non-comedogenic. 4. Picking. In many patients with acne, much of the skin damage is self-inflicted. Although the temptation to squeeze a fresh pustule is often overwhelming, it should be vigorously discouraged because it can produce more tissue damage, sometimes resulting in post-inflammatory hyperpigmentation and scars. Course and complications. With therapy, the prognosis for acne is good, if not excellent. The patient should understand that most therapies provide control of the disease rather than cure, and that improvement does not occur overnight. The only potential cure, other than time, for acne is isotretinoin. The recommendation is aggressive, upfront treatment that is tailored to the type and distribution of acne. Improvement is typically seen after 2 to 3 months of therapy, so managing the patient's expectation is critically important. Systemic antibiotics are recommended for 3 months and then should be discontinued. Bacterial resistance to antibiotics is becoming more frequent, thereby limiting the usefulness of long-term antibiotic therapy for acne. Most patients require prolonged, often lasting for years, maintenance therapy with topical agents. If acne is not responding to systemic antibiotics and topical therapies, then referral to a dermatologist is warranted. Isotretinoin induces prolonged remissions, if not cures, in many patients. Acne remits spontaneously with time, to a degree that varies widely. For individual patients, there is no way to predict in advance when they will outgrow their acne. The goal of therapy is to keep the condition under control for as long as it is active. The major complication of acne is its psychosocial ramifications, which can be devastating for some patients. Patients with severe cystic acne may even be socially ostracized. In an ironic quirk of timing, acne occurs at a time in life when personal appearance is a prime concern and self-consciousness may be at its peak. Regardless of the severity of the acne, for patients seeking help, even those with apparently mild disease, the disease is important and deserves serious attention.
Patients are not impressed with soothing advice that trivializes their disease and reassures them that they will eventually outgrow it. In addition to the cosmetic liability of active lesions, scars further compound and perpetuate a poor self-image in some patients long after the acne has remitted. Scars are difficult to treat. Dermabrasion, laser resurfacing, chemical peels, and surgery have all been employed, with varying results. Because scars are more easily prevented than treated, the emphasis on acne is on early and aggressive medical therapy. Pathogenesis. Multiple factors are involved in the pathogenesis of acne. The 3 most significant are as follows. 1. Androgenic hormones. Under androgen stimulation, sebaceous glands enlarge and increase their sebum production. Before puberty, the responsible androgens are secreted by the adrenal gland. During puberty, the addition of gonadal androgens provides further sebaceous gland stimulation. 2. Follicular obstruction. For acne to occur, outlet obstruction of the follicular canal is required. All acne lesions begin with a microcomedone. This obstruction occurs because of the accumulation of adherent keratinized cells within the canal, forming an impaction. The cause of follicular obstruction is not known but may also be influenced by androgens. 3. Bacteria. Proximal to the follicular outlet obstruction, sebum and keratinous debris accumulate. This provides an attractive environment for the growth of anaerobic bacteria, specifically Cutibacterium acnes, Propionibacterium acnes. These bacteria produce lipase enzymes that hydrolyze the sebaceous lipids, resulting in the release of free fatty acids, which are presumed to cause inflammation, another important factor in acne. Cutibacterium acnes play other roles in the pathogenesis of acne. Example, these bacteria are chemotactic for neutrophils. Regardless of the mechanism, the therapeutic benefit of antibiotics supports the notion that bacteria play a pathogenetic role in acne. Thank you for your attention.